thank you so much for letting me come and speak with you. I promise this is not going to be a data presentation. I do like data, but we're going to try to branch out a little bit. You've heard some of the messaging thus far, and you're going to hear a lot of the same. So, guys, y'all did a great job of getting everybody on the same page from what I can tell thus far in terms of you'll see some of the same information, but hopefully from a slightly different spin. So thank you, Tammy, Amy, Janice, all of the folks who I was emailing, trying to pull this together to get the information to be able to talk with you all. So I'm really pleased to be here and appreciate the opportunity. So I want to give you a little bit of my background. You heard sort of the fancy stuff, but just to give you a little bit more of the meat of sort of my lens of where I'm coming from, just so hopefully it'll make sense in terms of what we'll be talking about for the next little bit. My vantage point is population-based public health. So very much, I'm not a clinician. I was talking to a friend and colleague who was a clinician, and she said, go in with that. So I'm not sitting in your shoes. I'm not providing care. But what I do hope that I can do is kind of help you have that 60,000-foot view of the whole healthcare system, not just the medical care system, but the true, what I would call the public health system that incorporates all those pieces. So that's one part of it. Excuse me. So really focusing on all levels of prevention. Primary, secondary, and tertiary, which is what many of you are involved with. And certainly you're involved with primary prevention, but when you have a pregnant woman sitting in front of you, there's some marks that you've already passed. So trying to see from that vantage point. And also maternal and child health systems. Dr. Biggio mentioned that I'm the director of our maternal and child health training program, and that's actually a maternal and child health bureau funded. It's a Title V SPRANS project. So our students are trained to be maternal and child health leaders in the field, in public health specifically, and we work with a lot of other programs. We work with the state on various projects, home visiting, and some other pieces that I'll mention in a little bit. So again, coming from that systems big picture perspective, and we'll get more into that as well, and truly trying to focus on the core functions of public health. If you've been to a CDC conference, you've seen the assessment, policy development, and assurance. That's where my focus comes in, and how those play out we'll talk about a little bit in a minute. So really trying to focus on all of the pieces of the puzzle related to healthy populations. Moms, babies, young children's fathers. We have this conversation all the time. What is maternal and child health? Well, is that just children and families? No, it's bigger than that, and really trying to set the stage to say it is more than that, and it is certainly a larger group of people than we might think of just that small definition of pregnant moms and babies. So really trying to expand that. And recognizing that the public health system encompasses all other systems, a lot of other systems. We've mentioned education. We've mentioned early childhood systems, and some of those pieces that we can interface with. And my training is in public health and in perinatal health. I might have quite a bit of training in perinatal epidemiology. So again, just giving you a little bit of background of where I'm coming from. So I'm going to try to speak a population-based language, and hopefully what that will let you do is to as I'm talking, you may say, oh, I've heard this, I've seen these data, I'm very familiar with it. But hopefully this lens that we're trying to set the stage with will help you say, maybe we could tweak this in our program. Maybe we could connect with this group of people. So I would challenge you to get a piece of paper out and do some brainstorming, if you would, while we're talking. So that's my hope for you. I don't know if the information necessarily will be new, but maybe something new will strike you as we're moving through this. So why are we here? So you can see, this is, I think Dr. Williamson had this slide in his set. But just as a comparison where we are in relation to the national average, we're 8.9 per thousand in 2012, and the latest data that we have from the U.S. is from 2011, and that's 6.0. So a pretty big discrepancy there. So you can see here the Alabama infant mortality rate among blacks is 14.4. In the U.S., it's 11.4. Alabama infant mortality rate among whites is 6.6. And then for whites in the U.S., it's 5.1. So we've got some work in both areas, I think, certainly, to consider. So it's not, black infants are more than twice as likely to die compared to whites before their first birthday. And I think in a group of folks like this, that's not surprising. But if you say that to the general public, there are a lot of people who say, I didn't know it. I didn't know that. You've never put it into terms like that for me. So I think that's our charge as well. So for neonatal mortality, which is measured as less than 28 days, just wanted to illustrate this piece of the pie. We're still higher, 4.0 per thousand in the U.S. and 5.8 per thousand, and that's actually gone up from 2011 and 2012. So those first month deaths have increased. Post-neonatal mortality, and just to mention, and I think most of you know this, but the differences between the causes of death related to neonatal mortality, those early first month deaths, versus the post-neonatal mortality deaths. For a long time, we talked about kind of those separate etiologies, that neonatal mortality was really more related to preterm birth, to early deliveries, things that were more kind of with the mother. And then the post-neonatal mortality was more kind of external, SIDS, unintentional injuries, et cetera. And now, because of what the wonderful things that we've been able to do with technologies in the NICU, et cetera, those lines have blurred a little bit more. So some of the babies that we're seeing, not all of the 24-weekers, that may be not the best example, help me clinicians, not all of the 24, 25-weekers are dying in that first month. We're able to push that out a little bit. So again, the numbers kind of get a little bit blurred there, just as a point of reference for you. So think about why we're here. We've set the stage pretty clearly for that. And the goals of this presentation. What I want to do is introduce and highlight some basic concepts of life course perspective. And my inclination is this is not completely new for most of you, but I'm going to try to make it somewhat new, or as new as we can. So, and just to give you some different ways to think about it, perhaps, and to give you some ways to think about it in the context of our Alabama-specific data and our systems and our issues. And also to illustrate the need for systems-based or life course approach to health in general, specifically looking at infant mortality, but I'm going to, at the end of the presentation, kind of pull back and talk more about health in general, because I think that's a very important thoughts, and really broadening our thoughts about potential areas for interventions. And maybe hopefully pushing you in that direction. Although you may already be there, and if you are, I hope this does give you some time to process that, because sometimes I'm betting that it's hard to sit down and think about these things when you're responding to patients, you're responding to clients. So really having a minute to take a step back and say, gosh, what is going on? What could we be doing that we're not? And then being able to come up with a plan to say, okay, me, myself, and I, in the 50 different hats that I wear on a day-to-day basis, what could I be doing? And then taking that to say, okay, what could we be doing as a state? And what could we be doing as a group of people that are interested and passionate about this topic? So this is the slide that says, I borrow shamelessly from other people, and most of them know it, or most of them are okay with it. So just to give you a list of folks that a lot of these ideas and slides are credited to, and where they've come from, et cetera. And a lot of these folks are good friends. A number of them have actually been to our state and have conducted presentations, or will be coming back. Sherry Pies and Milt Cuddlechuck have actually been here before to talk about life course in various settings. Sherry Pies will be back in February at UAB, and we're going to work with ADPH and Michael Smith's group to get that as a satellite broadcast. and hopefully continue this conversation of perinatal outcomes and life course. So again, a way that we're trying to connect the dots on our MCH Public Health, School of Public Health end. So what is life course? You hear life course theory, you hear life course perspective. I would argue that it's a perspective. I would argue that it's a lens through which we view any health issue. Pick an issue, but today we're going to pick infant mortality because I think it's the strongest, you can make the strongest case for it. And it really helps us make sense of problems, issues, and solutions. So helping us understand, explain, and improve the health and the disease patterns across population groups. And I think that's key. And life course suggests that this is not a simple answer. I think we've heard that a couple of times. Very complex interplay of biological, behavioral, psychological, and social, both protective and risk factors, and how those work. So I'll talk in a minute about whether we increase protective factors or decrease risk factors. What do you pick? And sometimes it depends. So, thinking about our upstream problems, that primary prevention piece, and our downstream problems, again, those tertiary things that we deal with when a mom is already sitting in front of you that has gestational diabetes or that's had that short interpregnancy interval. So really trying it gives us some freedom to look across the span with those issues. So life course gives us the element of time, and I think that's important. It's important, it's freeing, but it's also frustrating in many ways. Because the life course approach recognizes that time allows us to shape health. That these flat models that we talk about are okay, but really when you dig down into I'll talk about the individual level. If you look at a woman's history, there are some folks that do everything right. They do absolutely everything they're supposed to. They don't smoke. They take folic acid. They do exactly what it is that they're supposed to do, and they still have an adverse outcome. And that's a very important group to recognize. But then there's also this other group that you get them, and quite frankly, they're sitting in front of you, and you say, "What a mess." And that's not a commentary on anybody, but that's the piece that they're already sitting in front of you, and you think, "Oh my, what can I do?" And we talk about that in the population. You think, "Oh my, what can we do?" But what life course lets us do is expand that a little bit and say, I might not be able to do anything for this person sitting right here, although there probably are a lot of things that we can do. But what can I do for this mom, this baby, over the course of time in terms of making not just addressing perinatal outcomes, but really helping these folks be healthier. So certainly we've talked about poverty, and that's a huge piece of the pie. But I'll be honest, you sit down and you say, I don't know how you all felt, but you thought poverty, and I went, whoa, that's a big thing to tackle, a very important thing. And again, I think talking through and thinking through what are the systems that I interface with as a clinician, as a provider, as a public health person, as public health people, I should say. What are those systems that we interact that have that influence on poverty? And really thinking that is money enough? So giving someone a pot of money and saying, go and be healthy, probably not going to work. So saying, I'm going to give you some education. I'm going to build a better system to where your children can go to a good school, get a good education. They can have a meal in their tummy when they get to school every day. So thinking that kind of thinking to say, all right, it may not be today, but it could be over a lifetime, and we have that opportunity. So I think it does sort of, again, it makes it more pressing and it makes it a little bit scary, but at the same time it does free us up a little. This perspective does free us up a bit. So life course in some ways is old and in some ways is new. It kind of marries this long-term MCH concepts with new science. I don't know how most of you were, but Life Course came out a couple of years ago, and no offense to Michael Liu or Neil Halfon by any stretch, but you kind of sit back and you go, yeah, got it, makes sense. To those of us who know MCH, know this population, it's sort of a gut, yeah, that makes sense. But what do we do about it? That's the key. But just to give you a little bit of the science background, Barker hypothesis, which links low birth weight to increased risk of heart disease and diabetes. So the idea that if you're born low birth weight, you have an increased risk of these things. The Philides ACE study that links early childhood adverse events to increased risk of obesity, heart disease, diabetes, and depression. So again, intergenerational and interconnected beyond just lifespan in and of itself. Neurons to neighborhood, environment, huge. You know, I think about, had a conversation with somebody the other day who was saying, you know, we go into, she's an occupational therapist, was going into homes, had her nice clean box of toys, and looked around. There was not a nice clean box of toys with these children. There were chicken bones on the floor that they were playing with. So learning that environment and being able to see that as a part of our home visits, as a part of the things that we do interacting with these families as a part of this larger system is really important. So understanding that early environment also is a huge part of healthy brain development. And then Lou and Halfon, of course, as you'll see a model in a minute, they linked disparities in birth outcomes to differential developments, trajectories, and critical and sensitive periods. So there's two things really going on there. And then epigenetics, certainly linking environmental triggers to gene expression, and that's certainly still a new area. And then thinking through the public health implications or how we intervene with that is certainly a challenge. Okay, so hopefully you all have seen this before. The socio-ecological model, again, not new, but this is just, if you can keep this pie in your, actually it's not even a pie, I kind of call it a slinky when I'm talking to my students, sort of seeing it as a slinky that with Life Course, if you take the socio-ecological model and pull it out, that's your longitudinal intergenerational perspective. So in the center of the circle, you have that individual behavior. Yes, if we could go into every home and change how parents interact with their kids and keep the mom from, make sure she has plans for education, for birth control, all of those things. But that, again, a daunting task. The individual behavior, the social and family and community networks is certainly another part of that. What does the community look like in which you work? Are there supports in place? And then beyond that, the living and working conditions. Psychosocial factors, employment status is certainly a big one right now. SES, income, education, as we've talked about, and the natural and built environments. You know, thinking about pregnant mom, you need to get more exercise. Well, gosh, I live in a community where there's gunshots being fired. I'm not going to get out and walk. So really taking some of the things that we talk about with children, with obesity, et cetera, and you hear these examples, but really trying to bring that to life. And then finally, that broad social, economic, cultural, health, and environment conditions and policies. So that big circle being the policy piece. So I think in many ways, some of us start out here and come in, and others of us start in the middle and go out. But either way, there's got to be some meeting between the two. I think if you buy into this model and the things that are and believe that this could have an impact. So some of the life course concepts I mentioned, T2E2, which again, if any of you have kids that are into Star Wars, or you yourself are into Star Wars, screams something to me. And I think that was the intention of the authors. But the timeline, the idea that health is cumulative and longitudinal, and I've mentioned that before, that really it's developed not just in a single, you're not pregnant and bam, we've got an opportunity to fix it. It's over the course of a lifetime. And timing, that health and health trajectories are particularly affected during critical and sensitive periods. And I think why infant mortality and why perinatal, why MCH has sort of the corner on this life course is because there's so many critical and sensitive periods during that time. You have conception, you have pregnancy, you have early childhood. All of those places where we have the opportunity to intervene is important. And what that does later to subsequent birth outcomes is really important. We have the environment, as I mentioned, that broader biological, social, physical, and economic. And health equity, I think, is an important piece of this. We talk about disparities, and there's been a lot of work nationally and in the literature of talking about flipping that term just a little bit and talking, instead of talking about health disparities, talking about health equity. And this is not anything new. This has been a conversation that's been going on for a while, but really understanding that health and equity goes beyond just personal choice or genetics. So trying to get that into the mix too. So here is a model that was published in the Maternal and Child Health Journal in 2003. And on the x-axis, you can see the lifespan and its critical or sensitive periods laid out across the life course. So the idea that that life course on the bottom, your bottom right of the screen, that reflects that intergenerational piece of moving forward. Certainly the idea that the upper line would indicate white reproductive potential, and you can see those arrows pointing up being those protective factors, and the arrows pointing down the risk factors. So seeing that with this particular vantage point, if you're talking white-black disparities, there are fewer risk factors for whites and fewer protective factors for African Americans. So again, I mentioned, what do you pick? Is it fewer risk factors or more protective factors? And I think, again, this lets us kind of look at both. This opens up the idea of it's not necessarily fixing something. Maybe it's enhancing something that's already there. So again, as I mentioned, we know protective factors improve healthy and contribute to healthy development, and risk factors certainly diminish. We could go through the laundry list of risk factors for infant mortality, risk factors for adverse perinatal outcomes, and I'll talk about those in a few minutes, or you'll see, you've heard some today: short pregnancy interval, being unmarried, low maternal education, etc. So those are the examples of risk factors that make it harder to reach your potential. And you know, there's always those few folks. Again, in public health, we have a tendency to stereotype. And so recognizing, as I mentioned, the women who do everything right, but also there's also those cases of you've done everything wrong, but you still get a good outcome, and isn't that fantastic? So figuring out what it is, we talk about this in the child development literature, but what about those kids that succeed regardless of whatever is thrown in front of them? So trying to figure out that resiliency piece and really looking at that. Again, not necessarily just from the individual perspective, but really trying to take that up to a systems level and say, what are those pieces that we can build in to our systems, our one system, and then multiple systems that interface with that? What can we build in to have that impact? So what do we know about the issues that influence infant mortality? Okay, there we go. So in looking at your, I'm not going to go, y'all are going to have ample time to get these data, look over them, talk about them in your breakout sessions this afternoon, just based on some conversations that we've had. So again, that team did a great job of pulling all of us together, even though we didn't know it. But looking at our rate of preterm birth, you can see we've got about 15% of all of our deliveries are before 37 weeks. And that's higher than the U.S., which is 11.5%. And Dr. Williamson showed one variation of this, but I wanted to take us back a little bit and say, okay, so we saw 35 weeks to 40 weeks, I think. And this graph actually shows you 20 to 27 weeks, so 324.5 per thousand. 36.5, even in that 28 to 30 week, where you got a pretty viable You have a pretty viable delivery. I'm looking at the clinicians, hoping that I'll get a nod. Yes, you have a viable. And then even our 33 to 36 weeks, 9.1, and then 3.3 for what is now, what one would argue now, maybe it's not termed, the 37 to 41 weeks gestation. So just to say, earlier the gestation, the higher the risk. And again, low birth weight babies in Alabama, the infant mortality rate is 62.1. Normal birth weight is 2.8. So we have babies that are born too small and too early. And that's a big piece of the puzzle. So, and over time, one thing that I learned a long time ago, we haven't been able to touch that birth weight gestational age distribution. We've been able to do a lot of things to help with gestational age and birth weight specific mortality. So those early deliveries, those small deliveries, we've been able to hit that with our medical interventions. But what are we really looking at in terms of this specific, how do we try to get at these low birth weight and preterm birth babies? And we don't have the answer. But I don't know that we've fully given it our, I think we're doing a great job of picking the lower hanging fruit. But are the answers in things like poverty, systems development, et cetera? So again, birth weight, less than 500 grams, which there's some measurement issues wrapped up in that, because some could argue we shouldn't be looking at less than 500 grams because of limits of viability, et cetera. Maybe not. That's a separate conversation. But the lower the birth weight, the higher the infant mortality, too. So infant mortality according to payment method. So in Medicaid, which about 60% of our deliveries are in the state are to mothers on Medicaid, 9.7 per thousand. That's pretty high. Private insurance is 6.8. So you're looking at close to the national average there. Still a teeny bit high, but probably not statistically significant. And then you look at our self-pay population, 22.7. babies per thousand die before their first birthday. So looking at that to say, okay, what are the other, this is not controlled, I don't think this is controlled, I'm pretty sure this is not controlled for anything else, this is just a raw number. So thinking about that in the context of some of these other risk factors. Talked about SIDS a little while ago, and you can see in comparison to the nation, 43 per thousand in 2011 compared to 66 per thousand in 100,000 births, 43 to 66, Alabama versus U.S. So again, thinking through what are the other risk factors for SIDS deaths? SIDS or sleep-related deaths. This is SIDS specifically, but just to broaden that a bit. Excuse me. And I know there's an entire session on this afternoon, but looking at, this is Plan First, the Medicaid waiver program, which I'm sure all of you are familiar with, that provides access to Medicaid-eligible women in family planning services. Certainly a very important work by the Bureau of Family Health Services and the Health Department. And looking at this, from 2009 to 2012, there were about 241,000 live births total in that group, that particular population. About 7.3% of those mothers had long-acting reversible contraception inserted. So again, a good place for intervention, but what are the other systems that need to be fixed before that can happen? So the challenge is, I think there's a challenge in saying, yes, this is something that we want to do, but also thinking through what are the things behind this issue and what are the things ahead of it that we need to address as well. Because saying we're going to do this and then thinking through who are the players, what do we need, who do we need to engage, what do we need to look at, I think is important as well. And Dr. Williamson showed a different version of this slide, and this comes from the Pregnancy Risk Assessment Monitoring Surveillance. That's actually a CDC and DrPH survey that happens in conjunction. 2009, 2011, about a little more than 50% of our pregnancies were unintended. Now, there's the different, that were either mistimed or unwanted. About 12% were unwanted, and about 38%, 39% were just mistimed. And so really trying to help women with that overarching piece of saying, when do you want to have your baby? And that's, again, a systems issue, because when does a woman enter? When do most women go into the healthcare system? When they're pregnant. Thank you. When they're pregnant. So trying to back up and say, what are the things we need to put into place to look at that? So the birth interval, you can see, we discussed this kind of in a general way, but just kind of giving you the data. With a birth interval of less than 2 years, we have an infant mortality rate of 9.1. If it's greater than 2 years, the infant mortality rate is 8.0. So again, still high, but there is a difference there in being able to address that. So we have low rates of LARCs, the long-acting contraception, and roughly half of all of our pregnancies are unintended, either mistimed or unwanted. There's an opportunity there, I think, certainly. So increasing our access to contraceptive services may be one thing, and again, knowing that that's going to be part of the conversation. But again, challenging us to get beyond an idea of one woman, one LARC, one IUD, one pack of pills, trying to say what could our system look like to address this issue differently. Dr. Thomas mentioned chronic conditions earlier, and looking at our diabetes and hypertensive rate. And the first time I glanced at this slide, I thought, oh wow, 89%, 87% of our pregnancies, but it's per thousand. I was looking at it wrong. 87.3 per thousand live births are to women who have hypertensive disorders. So that's pretty high. It's not that far off the national average, to be quite honest. I was surprised when I looked at that comparison. But again, opportunities there. And diabetes has actually stayed fairly consistent, but our measure of diabetes, what kind of information we can get on women who have diabetes, type 1, type 2, it's all kind of mixed in. So that's a little bit of a challenge measurement-wise. So some areas that I think we've hit on in one way or the other across the morning. Socioeconomic status, poverty, certainly a big piece of the puzzle, and with things like education, being able to address poverty. Social support is another piece. Pre-pregnancy planning, or even if you don't want to be pregnant because one day you may end up pregnant, planning. Just women's health in general. STIs are certainly a factor in adverse birth outcomes. Preconception care, a big piece of the puzzle, and pregnancy spacing. And again, looking at this from a population focus, not just the one-to-one piece, but really trying to say, are we putting things in place that make a difference across the board? Substance abuse, smoking we've talked about, alcohol use during pregnancy. Again, not very many pregnant women are going to say yes. That's a hard thing to measure, but we know it happens. Maternal risk factors, nutrition is a big piece of the puzzle, I think, sometimes underestimated. Are there any nutritionists in the room? There's not. So maybe that's something for us to consider. Engagement of the nutrition community as a part of this. Overweight and obesity, where does Alabama rank with that? What does that do in terms of deliveries? The ability to delivery, I would say, based on what I understand, that makes a big difference. Hearing fetal heart tones, feeling kicks, etc. That's a big deal. So, and the reduction of diabetes and hypertension. And the last piece, and again, this is such a sticky issue because of I think largely because of the system of care, but mental health. And I don't know that I've heard anybody mention that here, but I know that's something that's near and dear to everybody's heart, certainly, because there's only so much you can talk about in a given time span. But that being a piece of how do we link in with those mental health pieces, because that is so important. I remember the first time my baby wouldn't have, she's 5 now, but the first time she wouldn't stop crying. it got to where it wasn't very pretty, and I took a breath and I thought, wait a second. I'm highly educated. I've got a great social support. I have a husband that's just down the hall, and thankfully he came and took the baby from me, and then I went and had a moment. Probably went in the backyard and cried. But thinking about what happens to that teen mom, what happens to those groups of people that aren't like me. Are we doing what we can for that group? So from the mental health point of view, and knowing that that's an instance versus these long-term maternal depression and other issues that we're dealing with that we're probably going to see an increase in over time. So I think that would be something that, as we're talking through these issues, the mental health status of women in pregnancy in general, but then also even taking that to the next step to say, what about the mental health of women who have had these experiences of infant mortality? And do we have some good things in place for that? And I know I'm preaching to the choir on some of these things. So this is, for those of you who are involved with MCH specifically, you're familiar with this pyramid. And I want to talk just a minute about Title V, which is Title V of the Social Security Act, and it's federal legislation, and it was put into place in 1935. And the charge of Title V is to care for all women and children. And I think in many ways, sometimes our challenge in public health is, oh, well, you just care for the poor. Oh, it's still, even though there's the branding of we are for everybody, and I think the health department has done an excellent job in many, many areas. But the one thing that struck me watching these slides earlier with this idea of a public awareness campaign. Who is your public, and who are you trying to increase awareness? Because I would argue, yes, it's very important to educate and to raise awareness among those women, or those families, I should say, moms, dads. Dad's health is certainly important, or men's health. But also taking a step back and saying, but wait a second, don't we need to grab the attention of the people that have the power to make the changes? So those people that don't have an experience with poverty, with low education, with all of these other risk factors that we've talked about. So really trying to branch out and say, does everybody know that a black baby in Alabama is twice as likely to die in comparison to a white baby? Probably not. And are we doing a good job of getting that message out? Because I can guarantee you the friends that I have that I've talked to when they say, what do I do? And I don't make their eyes glaze over with data, I promise. But having just that one sentence right there, folks go, wow, I didn't know that. So trying to think big in terms of who we engage in this process, I think is part of the piece. But going back to my soapbox, but going back to the pyramid, looking across the spectrum of what it is that maternal and child health and what it is that you all are involved with. So the direct health care services, again, that individual, if you think about this as that first model that I showed you with the slinky, the inside of the slinky, if you will. The basic healthcare services, the enabling services, things like translation services, population-based health, immunizations, and then broadly that infrastructure building services looking at the policy. So it runs up and down the pyramid in terms of what has to happen to really adequately address infant mortality and adverse perinatal outcomes. So changing our scope of work just a little bit. And thinking about that in the context of the Affordable Care Act, there's some wonderful things that are built in. There's some blessings and some curses built into the ACA, I think, in many ways. I think it gives some good opportunities. But then thinking through, ACA can't do all of these things, even the small pieces. So recognizing that there certainly is a role for Title V, maternal and child health, the folks in the Bureau of Family Health Services, what they're doing, and again, telling you these activities, but also saying, be a part of this. Where are you in the pyramid, and where do you need to connect with other pieces on the pyramid, I think is my message there. And then also trying to frame this in the core public health functions. Again, the assessment, so looking at things like data, being able to assess needs, going out and talking to people, talking to the community. If that's not something that you're doing, you should, if you say that's not my job, you should be connected to somebody who that is their job, and working to get that part going. Developing policy. Certainly there's a lot of exciting things with the COIN initiatives that are going on, and with all of this conversation with the elective delivery reduction, et cetera, and even those bigger picture things that hopefully will happen here. And then assuring that those things happen. And that assurance can happen at the individual level, which I know many of you are involved in, but also, again, kind of pulling up to the assurance at that systems piece. Are we connecting those dots as we should? So I would argue that the Title V, or the what we know as maternal and child health, public health, allows for a systems approach or a life course perspective to issues addressing the continuum of needs for a population, where the ACA, I think, provides some mechanisms for systems like home visiting, but largely it focuses on access and insurance issues, which again are big pieces to the puzzle, but really trying to supplement and see how that all fits together. Things like Strong Start, not a part of the ACA, but that's certainly a big piece of the puzzle. Women's health is part of that as well. There's a piece in the ACA about teen pregnancy, and that's certainly important too. So learning that we've got to fit the MCH system of care into the life course perspective. So recognizing that we talk about life course as a perspective, as a framework, as a theory, but does it really work? And what do we need to do to make it happen? So you may say, great, fantastic, you gave me some good things to think about, but I'm not sure what to do. Collaboration. So this is what I would say back. Take a step back today as you're in these working groups, as you're talking through these things that we need to do, because I think all of the goals here that have been outlined in terms of what to discuss are really important, and there's some tertiary prevention measures that could be put into place now, and they would probably make a good impact. But what I would challenge you again to do is to think through what's bigger than that. What do I need to connect with? Who do I need to connect with? Is there something that's going on in my office that I say, you know, I'm not really sure what's going on, or do I just need to think a teeny bit more outside the box and then see where that goes? And you may say, I'm tired, I can't think out of the box anymore. But maybe today, away from the office for just a minute, you'll have a chance to do that, and to do it for the folks that you serve. So again, just to think about this idea of the arrows may be different for different people, but when you combine all of those arrows, either protective or risk factors, you're going to hit a group of folks. So you're going to make an impact in more than one if we can figure out this idea of risk factors versus protective factors. And again, thinking through, is it removing the risk factors, or is it increasing protective factors? And like I said earlier, I think it's both, but kind of framing it that way. Again, the socio-ecological model, the best, thinking through this example, you know, think about the moms that you serve whose babies are in the NICU. I think the NICUs that I've been in, they're nice. They are pretty. The one at UAB has that beautiful hardwood floor. It looks fantastic. And those mamas, you walk in there, what are they going back into? Are they going back into a system that allows them to, or are those babies going into a system that will take care of them, that's easy to navigate, that is connected, collaborative? Probably not. And so again, this is where that systems orientation said, that systems orientation comes in, of saying, how do we build that system of, once we get these tiny babies, once we get them well, the tertiary prevention does its wonderful job, and then we move them out into this new system of care, the early childhood system and other children with special health care needs, et cetera, moving out into that realm, if needed, I should say it that way. What does that look like? And how do I have an onus to see what that looks like, and to take a look at that, and to see where we can make a difference. So I think this is a nice summation of where we have to go. We touched on the scientific evidence related to life course, but there's a whole lot more. At UCLA, there's a group of folks, and actually it's not just at UCLA, it's housed there, the Life Course Research Network. And in the back of these slides, I've actually included a link to their website. They've got some great work that's going on how to make sense of this from a scientific perspective. And there's certainly the political will to do this, and the social infrastructure. And as I mentioned, it's not just I don't think it can be just among those people that are at high risk. It's got to go beyond that. So Governor Bentley mentioned jobs. So thinking about what involvement or what responsibility does Honda have in this? What responsibility does Mercedes have? Our other big corporations, how do we engage them in this conversation and say, hey, you need to care about this, because it's the health of your population, it's the health of your workers, your future workers, and wanting them to be a part of that. So again, that public awareness piece. So the public awareness campaign beyond just who's at risk. So getting into, how do we know this is working? Because I think the measurement and saying, state legislatures, you gave us hopefully $4 billion. Yeah. Oh no, that's sad that you laughed. $4 million. You gave us these funds to do this. So building in some measures to say, there's some short-term outcomes. We can't change infant mortality in 4 months. It's just not possible. We can't do that. But what we can do is say, okay, here are our life course metrics, and there's actually a project that's going on at the Association of Maternal and Child Health Programs that's laying out some data sources, metrics, et cetera, that help in this measurement piece, that will help us move along the continuum to say, yes, our overarching goal are these long-term outcomes, reduction of infant mortality and related causes, but back to the legislators who have given the money, well, you didn't make a difference. Well, but wait a second, we did this. And so really being strategic about how we pick those short-term and long-term measures, I think, is very, very important. And making sure that every activity that you have is measurable and has outcomes and has goals, et cetera. So that's, from the evaluator hat that I sometimes wear, I think that's a very important piece for that accountability. And really trying to help us, on that same note, really trying to help us get beyond that snapshot of time. So you'll notice a lot of these data, these are from the vital statistics, birth certificate data, linked infant death data, surveys, et cetera. So thinking through, what are data systems that need to change? Are there tweaks we need to make in our data system in terms of being able to link birth certificate with FEMUR data, with fetal infant mortality review data, with Medicaid data, et cetera. So again, trying to be able to build in those pieces of accountability, and recognizing that, that may be on a program level, that may look one way, and then on a state level it may look another way. But again, creativity and knowing that costs money, but saying, what do we want to shoot for? What's the goal? So because the question really is, how do we measure what we're preventing? So if you go beyond just that snapshot of being able to have a more longitudinal perspective with these families and with these children, can we get a better glimpse of what we're doing? There we go. Finally got it after the 41st slide. So I think again, as I mentioned earlier, I think the life course perspective allows us to get beyond the usual suspects related to infant mortality reduction. So again, it frees us up, but it also binds us to keep going. So it frees us up to look at some things that maybe we hadn't thought of before, or to be more creative and say, you know, if we engage one more person, does that lighten the load just a little bit in terms of what we're doing? If we engage one more group, and recognizing working with groups, that also makes it more challenging, because collaboration is hard, but it's very needed. That our systems focus is really not just within one system, that it's multiple system. If you think about a pregnant mom who's on Medicaid, how many different systems does she interact with on a day-to-day basis, or in a given 9 months? Medicaid, if she smokes, tobacco cessation, right? Which is there's a system within Medicaid that does that. Medical provision, health. I mean, there's so many different pieces of the puzzle that this one woman who is representative of a bigger population interfaces with. So again, the opportunities are very broad, and there may be some easy low-hanging fruit, but then there may be some bigger ones. And also, you know, that really it's that one fix of a system is not just affecting that one mom, it's affecting her children, which affects her children, which affects her children. Again, that intergenerational, and we talk about that, breaking the cycle of poverty in the midst of all of that too. And I think that's one of our greatest challenges. So as a born, raised, bred, schooled, etc. Alabama girl, Birmingham Southern, not University of Alabama. My husband and I both are from here. We are raising our child here, and we're very thankful to be doing that. And I think recognizing that we should be proud of the state that we have, and doing this is so important. And knowing that there are more strengths in this state than we realize, and I think some opportunities that we have that other states don't, and taking advantage of that. And I think one of the things that Dr. Williamson mentioned, and I'll put it in slightly different terms, of neighbors taking care of neighbors, regardless of who that neighbor is. I think that's certainly one of our strengths of doing that. And you know, I think these two quotes were quite striking to me. It's the greatest poverty to decide that a child must die so that you may live as you wish. And then the world is a dangerous place, not because of those who do evil, but because of those who look on and do nothing. And I'm pleased and so proud to be a part of this, that we are not doing nothing on this. So I appreciate the opportunity, and I'll stop there. I've given you some resources and references in the back of your slides. Many of these projects you've probably heard about, just some examples of local groups that are working, some national organizations, some references, etc. So if you want to take a minute to look at that, I hope you would. But again, thank you for the opportunity. Very proud to be a part of this, and appreciative of the opportunity for it. And I hope, again, it just gave you something to think through, and maybe a little bit of motivation to say it seems daunting, and yes, it is, but at the same time, it also frees up some opportunities for us. So thank you.